of mathematical equation, we had come to know that the success of interlocking knitting is equal to A into C into B into Z. Whereas A is the expertise in the art of the freehand technique of locking, whereas the C, B, and Z are the respectively the availability of the C arm in your roti and protective sleeve in your special instrument set and G in your special instrument set. If you increase the value of A to such an extent that the Z becomes zero, like independence of the G becomes zero, this creates a scenario where the surgeon has mastered the freehand technique of locking and can perform both proximal as well as distal locking without the G. So this is the mathematical basis. We conducted a study between March 20 to March 25 on 100 cases of non-articular fracture of the tibia done by Dr. Thakur innovative technique of learning of tibia. So along with the other instruments, we had two pilot instruments. Number one, a color-coded tibial and extractor, which is present in intrapatellary set, and a more improved version of the color-coded tibial and extractor for RCT introducer composition to introduce the rail. This is the scheme incision. You can see the transverse incision has been given, vertical incision also. And this is the innovative part of this innovative the innovative part of this innovative technique, the introduction of the trocar and protective slip from BFN to set inside the retropatellar space. Third picture shows the innovative part of this innovative technique, that is the proximal locking by freehand technique. So after making a hole just medial to the lateral tibial spine, we introduce a variable guide wire. After percutaneous reduction of the fracture with the percutaneous portions, and after serial leaving we mounted up to field side, then over the color-coded tibial and extractor on RCT introducer composition, and finally we introduced the proximal as well distal locking by freehand technique. So this is the flow diagram, nothing to repeat it again, and this is the post-operative follow-up steps. Again, we all are aware of this. This is same as the incomplete learning of tibia. No patient complain of deep pain in our series. All patients get full range of movement in our series by 16 weeks. I final follow-up with 4 cases found excellent results, whereas 13 had good results, whereas 2 had subacute infection at the screw site and 1 had infected non-union. The average time of union was 80 plus minus 10 minutes, whereas average fluoroscopy time was 38.5 plus minus 6.5 seconds. All patients followed 2, 3, 6, 8 and 12 weeks, and the average time of the union was 8 weeks post-surgery, whereas complete union occurred by 12 weeks in all our cases. These are the few cases, clinical and radiological pictures of the few cases done by Dr. Thakur innovative technique of learning of tibia. So the number of studies done on this innovative technique is small. I think this is the only study done by the although good number of patients were included. The study was not comparative with the standard technique, so status of cartilage over the pipeline metroclea was not evaluated in this study. There was further more studies required to compare this innovative technique. We had a high-tech presentation in IOACON and found a space in International Journal of Orthopedic Sciences. You can see, and this is a video we don't have time to show you. So the take-home message is this technique would prove a boon for a small and medium class hospitals situated in BSC breakdown in India and poor countries like Bhutan, Nepal and Bangladesh, where the allocation towards the health is very, very low. So this would prove also a very useful technique for Ayushman Bharat Yojana, which is the dream project of our Prime Minister, Shri Narendra Modi. Thank you very much for patient hearing.
Why do small YouTube creators fail to hit YouTube trending? Poor titles, weak hooks, and outdated keywords kill your views before they start. That's why I recommend the USEO app.
The digital teaching that the 99.99% of these cases unites without any significant deformity and without any significant functional impairment. But later on, it was found that there are severely displaced fractures, severely comminuted fractures. About 15% of cases require surgical treatment either in the form of tense snelling or the open reduction and internal fixation with plating. So let us come to our main topic, that is that tense steady, unlike conservative management, it provides stable fixation and early mobilization of non-union and mal-union. Tense incision reduce soft tissue damage and fewer potential complications, making it an attractive option for managing distress fracture of the clavicle. So we conducted a study between March 2022 to March 2025 on 25 cases of clavicle fracture, mid-third fracture, all were simple distress fracture according to AO classification 15D1 and 15D2. The age of the patient was 16 to 48 years. No comorbidity was found in our study group. So all patients treated by titanium elastic nulling in my hospital. So the mode of trauma, road traffic accident was the main mode of the trauma, whereas fall from height and fall on out the state side was the other mode of the trauma. So these are the typical mode of injury, the fall on the shoulder to protect the head injury in the road traffic accident. This picture is taken from AI, and this is the typical clinical presentation, a bump at the site of the fracture, and the skin appears as if the fragment will penetrate the skin, and this is the radiological typical presentation, more than 2.5 centimeter displacement, and the jet type of cognition are the radiological indication for the surgical treatment, either in the form of tense or internal fixation with the plate and screw. So these are the already explained. The simple fracture were taken into consideration. Distressed simple fractures, either spiral or oblique or transverse or short oblique, 15B1 and B2. The patient lies supine on the affected lip elevated and the arm are hanging outside the table, so that we can facilitate the abduction and external rotation at the shoulder to facilitate the reduction of the fracture by closed width. The incision is small incision, has a transverse or longitudinal incision about 1 to 1.5 centimeter. Just lateral to the sternoclavicular joint is given, and after making an incision, we make a hole with the help of drill bit, and then we make this hole continuous with the intramedullary canal of the clavicle. But this is very, very crucial step. One should take his own time and use tips and tricks to do this step, because the heart and lung, like vital structures, are waiting for an instrument to escape. So after making the hole, we did tense snelling after close reduction or mini incision reduction. So the immediate post-op pain management and immobilization, at the 2 weeks we did suture removal, at 6 weeks radiographic assessment of the fracture area, at 12 weeks the functional assessment, and if required the implant removal was done. And the operative time was 30 to 60 minutes, whereas fluoroscopic time was 10 to 30 seconds, and the blood loss was 20 to 50 ml in all our cases. So the excellent result in 76% of cases, whereas 16% cases were good results, and fair and poor results were 4% each in our study group. The complications are nail bite-out, superficial infection, and the malunion, each were 4%, whereas hardware irritation was 8% in our study group. And these are the few cases. You can see that 15B1 fracture treated by titanium elastic nulling, beautiful surgery without the use of any instrument. The reduction has been done only by shoulder movement, external rotation and abduction, and with the help of the thumb and index finger. The beautiful surgery. And this is another case, and yet another case of the 15B1 fracture treated by titanium elastic nulling, yet another case of 15B1 fracture treated by titanium elastic nulling. These are the 15B2 fracture, this is 15B3 fracture treated by titanium elastic nulling. Ideally, it should be treated by open reduction and internal fixation, but we did tense snelling, and you can see that 6-month follow-up, the beautiful radiological union. And this is the functional result. You can see time is less. So the limitation of this surgery is a small number of cases included in this case, in this study. So the short follow-up long duration of follow-up and prospective study is required to quality of treatment as a attractive option for the treatment of displaced fracture of the take-home message is tense nailing is effective for the clinical fracture with good to excellent outcomes, minimum complication if the patient are selected properly and the technique is performed properly. The further study are needed to confirm the long-term efficacy of this work. 17 years old man, the road traffic accident was the mechanism of injury, clinical presentation, severe pain and deformity. And inability to bear the weight on the right side, whereas the left side he had a garage fracture. So the challenge was the patient presented with significant surgical burden and the major long bone fracture concurrent with the complex coronal fracture and dislocation, which we call the garage fracture and dislocation. And this is the X-ray of the femur, the sharp femur, mid-third fracture of a 17-year-old gentleman, and the forearm Gallagher fracture, severely displaced fracture. Inner canal, it was narrow, so the nailing was difficult. The standard treatment is nailing, and ideal treatment for this Gallagher fracture is the plating. But I opted nailing, although it was difficult nailing in the both fracture and the slight distraction, the tense nailing for Gallagher fracture, and this is not reported in any literature for such a severely displaced fracture. The tense nailing should be considered. In fact, there is no literature present for the tense nailing for this type of Gallagher fracture. So we did for the minimally, because it is minimally invasive, and periosteal and endosteal blood supply are maintained in both fracture, and the interlocking nailing was done in the sharp femur, and only 9 millimeter nail could be negotiated because the narrow medullary canal. So there is slight distraction, as you can see in this picture, but we did locking. It was difficult nailing. So the goal was to provide sufficient stability for early mobilization despite of an anatomical constraint, and implant was 9 millimeter nail and technique was minimally invasive, and whereas in this left radius, the Gallagher fracture, we did tense nailing. In this case also, the 2 millimeter tense nail was used. Usually you use the 2.5 millimeter tense nail, but we use 2 millimeter tense nail. Still there is distraction at the fracture site. So this was the problem with this due to the narrow canal. This is the 6-month follow-up. You can see I sent the X-ray in Indian Orthopedic Research Group, IORG, and they told to revise this case, bone grafting and plating for Gallagher fracture. So, but I left it and wait for, this is the 8-month follow-up. Still there was better union than 6 months, but this was not hypertrophic, and this is 11 months. You can see, so after waiting 11 months, the union is complete in both the fracture. The secondary colors are been formed. It was not hypertrophic non-union, it was the union, secondary union was taking place, although it was delayed union, but This is the functional result. You can see that supination, pronation, and wrist movement, erection and extension all are present. And the tensioning provides sufficient stability for secondary union even in length critical fractures because the narrow canal and the length should be maintained and DRUJ should be reduced properly. We followed throughout the 11 months for this maintenance of the length and DRU maintenance. And advantages of this minimally invasive approach for allergy fracture and femur is minimally invasive and reduce operative time and significantly minimize minimum blood loss. And this is the conclusion that the TENS is viable, effective alternative for plating for the complex forearm injury. The successful management of this double fracture case confirmed that interlocking of femur and TENS as higher union rates and excellent functional outcomes. This approach should be considered for garage fracture. Follow for the fracture healing and by doing the functional assessment of the fracture and case. These are few cases. Neurological and see the one ST surgery finger was used to reduce the fracture. Neurological and see the one ST surgery finger was used to reduce the fracture and abduction and external rotation of the shoulder was used to reduce the fracture. But this does not happen. Many times we require the mini open reduction of the fracture. So this is another case we did. The 15B fracture treated by titanium elastic welding. You can see the 6-month follow-up, the beautiful union, the secondary union. There are 2 bumps in the clinical picture. You can see at the fracture site there is secondary callus formation. One bump is due to secondary callus formation. One bump is due to secondary callus formation. And other at the entry site you can see that there is hardware from this. So this is another case of the mid-third fracture treated by titanium elastic drilling. Yet another case, 15B1 fracture treated by titanium elastic drilling. Yet another case of 15B2 fracture treated by titanium elastic drilling. This is again 15B2 fracture treated by titanium elastic drilling. And this is 15B3 fracture. Ideally, it should be treated open reduction and internal fixation with a plate in screw. But we did titanium elastic drilling in this case also, and you can see that the beautiful union of the fractures at the 6-month follow-up period. So this is the functional result. Limitation of this surgery, a number of cases included in this study was small and the short period of follow-up, and this is the retrospective duration, and a prospective study is required to establish this treatment as the attractive modality of the treatment for the mid-third fracture of the clavicle. So the take-home message is TENS drilling is effective for the clavicle fracture with good to excellent results, the minimum complication with properly selected patient and properly technique performed. So the further studies are needed to confirm the long-term efficacy of this modality of treatment. So thank you very much for your patience here. ये फ्रैक्चर है टिबिया का
कई भागों में विभक्त है और इसे डॉक्टर ठाकुर इनोवेटिव टेक्निक ऑफ सुप्रापर्टिनल नेलिंग ऑफ टिबिया के द्वारा ऑपरेशन किया जा रहा है। इस वीडियो में देख सकते हैं कि गाइड वायर को डाला जा रहा है और गाइड वायर फ्रैक्चर रिडक्शन के बाद परक्यूटेनियस फोर्सेप्स के द्वारा बिना चीरा लगाए रिडक्शन फोर्सेप्स के द्वारा उसे रिड्यूस किया जा रहा है। और रिडक्शन के बाद मैल्लेबल गाइड वायर को सीआर के मदद से डाला जा रहा है और उसके बाद उसे मेडुलरी कैनाल को रीम किया जा रहा है और रीम करने के बाद नेल को गाइड वायर के सहारे सीआर के मदद से फ्रैक्चर को रिड्यूस पोजीशन में रखते हुए नेल को डाला जा रहा है। उचित साइज के नेल को सेलेक्ट करने के बाद उसे डाला जा रहा है। फ्रैक्चर रिडक्शन परक्यूटेनियस रिडक्शन फोर्सेप्स के द्वारा किया गया है। और अब नेल को डाला जा रहा है। हम नेल को फाइनली लोअर एंड ऑफ द मेडुलरी कैनाल डालने के बाद उसे अपर फ्रैगमेंट और लोअर फ्रैगमेंट को लॉक किया जाएगा। आप देख सकते हैं कि किस तरह से फ्रैक्चर का रिडक्शन हुआ है। ये है आरसीटी नेल इंट्रोड्यूसर कंपोजिशनर, जिसके द्वारा नेल को डाला गया है और अपर और लोअर फ्रैगमेंट दोनों को फ्री हैंड टेक्निक से सीआर के मदद से गोल करने के बाद होल को गोल करने के बाद इस तरह से सीआर को एडजस्ट किया जाता है कि होल गोल दिखे और उसके बाद उसे ड्रिल करने के बाद उचित साइज का स्क्रू डाला जाता है। देखिए बिल्कुल गोल दिख रहा है अपर फ्रैगमेंट का दोनों होल और उसके बाद स्क्रू डाला गया है। गोल दिख रहा है, स्क्रू डाला जा रहा है। अपर फ्रैगमेंट के लोअर होल में डाला जा रहा है। दोनों स्क्रू को उचित साइज के स्क्रू को अपर फ्रैगमेंट में लॉक कर दिया गया है नेल को और अब लोअर फ्रैगमेंट के एंट्रोपोस्टेरियर जो होल है उसको गोल किया गया है। इस तरह से सीआर को एडजस्ट किया जाता है कि वो गोल दिखे। और एंट्रोपोस्टेरियर स्क्रू को डाल दिया गया है जैसा कि आप पिक्चर में देख सकते हैं। और देखिए अब मेडियोलैटरल होल है वो गोल कर दिया गया है। इस तरह से सीआर को एडजस्ट किया गया है। और अब मेडियोलैटरल स्क्रू को भी डाला जा रहा है। ये मेडियोलैटरल स्क्रू डाल दिया गया है। और एक लंबा सा स्क्रू जो आप देख रहे हैं वो एंट्रोमेडियल स्क्रू है। ये तीनों स्क्रू फ्रैगमेंट में दिख रहे हैं। इस तरह से लॉक किया गया है बिना चीरा लगाए। छोटा छोटा चीरा जस्ट स्क्रू घुसाने के लिए रॉड में। और ये फ्रैक्चर है, आप देख सकते हैं कितना बढ़िया रिडक्शन हुआ है। 3 भाग में टूटा हुआ था। ये 3 लोअर फ्रैगमेंट का स्क्रू है, आप देख सकते हैं कितना बढ़िया अपर फ्रैगमेंट का स्क्रू है। ये आरसीटी नेल इंट्रोड्यूसर कंपोजिशनर के द्वारा डाला।
Hello friends, today I am going to give a demo of interlocking nailing in fractured shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the shaft femur. So this time the patient had come to me for the lower third fracture of the shaft femur or other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeter diameter, and then after blood dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the pyriform fossa in APQ. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am having the bone out inside the intermedullary canal so that it can enter
in selected exact in-clip point. And this is the lateral view. You can see that it is at the junction of the anterior two-third and posterior one-third. You can see in the picture, and every view, this is the lateral view, this is the every view, and this is the lateral view. Again, I have focused to confirm the in-clip line. And finally, after confirming in the CR picture the correct in-clip point, I am introducing by a screen movement of the CR, and you can see that this is the every view, it has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior two-third, at the junction of the anterior two-third and posterior one-third of the greater trochanter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guideline is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make an space in the lateral part of the bone out to introduce the guideline. And finally, after introducing the guideline, we remove this bone out, and then after reduction of the fracture, with the help of the F tools, my assistant is holding this fracture in proper position, and the guidewire has been introduced in the distal fragment. And after introduction of the guidewire, we are going to ream the medullary canal with the help of 9 millimeter reamer, and it is being reamed with 9 millimeter reamer, hand reamer, and it has crossed the fracture, and my assistant is keeping the fracture in reduced position throughout the nailing process with the help of the F tool. During nailing process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. And I am doing reaming with a 10 millimeter reamer, and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, the slightly distracted, but in reduced position, in every view, and also in lateral view. This is the oblique view, and after performing in the CR in both view, we did reading up to the lower end of the femur, and finally we removed this fracture with the help of power removal 11 millimeter. Because the patient is old one, so reading is easy. It is just to measure the size of the intermedullary canal, the diameter of the intermedullary canal, so what size of the nail should be introduced so that it can fit in the intermedullary canal. The fitting nail can be introduced. So this is the purpose of reading. Because the patient is old-born osteoporotic, throughout the nailing process, reading process and nailing process, the fracture is kept in reduced position by my assistant. And the fracture has been linked up to the lower upper end of the patella, as you can see in the CR picture. You can see in the CR picture. It is reduced, although there is slightly distracted, but in reduced position. And finally, it has reached up to the lower end of the femur. And now I am measuring the size of the nail with the help of the CR. And after selecting the proper size of the nail, I have mounted a 10 millimeter, a 11 millimeter, sorry, 11 millimeter nail on cheek. And finally, I am hammering the nail inside the intermedullary canal and keeping the fracture in reduced position with the help of my assistant, so that the malalignment can be prevented. And finally, I have introduced the appropriate size nail up to the upper pole of the patella. It is good position, the fracture is reduced in both view, in the oblique view and lefty view and lateral view. And then I will remove the guide wire before proximal locking, and now I am doing proximal locking after removal of the guide wire. So you must keep in mind that before locking you have to remove the guide wire. And I am doing proximal locking. And now I am tightening the screw. The second screw is the proximal fragment. As you can see in the CR picture, the proper size screw has been tightened in proper position, and it is confirmed that it is inside the hole in both FD and lateral view. And now I will do the distal locking by freehand technique. I will make the hole circular after adjusting the CR in lateral position, and I am tightening the screw after drilling with 3.2 millimeter drill bit. As you can see in this picture, and both the screws have been tightened and confirmed in anterior and lateral view. The size of the screw is confirmed in the FD view, and whether it is inside the hole or not, it is confirmed in lateral view. The size of the screw. So thank you to my assistant, my anesthetist, and all the supporting staff for successful surgery of this 72 years old female for fracture sharp femur, which had been operated on the other side elsewhere 4 years back. So this is on the whole a successful and well-executed surgery. Thank you. Hello friends, I am Dr. RCT orthopedic surgeon, Chhapra, Bihar. Today I will give a demo of PFN A2 surgery for a interprotective fracture of the femur. The design of the spiral blade provides a stable fixation of this fracture, and you can make mobile our patient. So today let us come to the surgery. This is the X-ray of 72 years male having osteoporosis with a fracture of the intertrochanteric unstable time. And this is the post-operative X-ray of the same patient. And now I am going to start my surgery. The skin incision, before the skin incision, I will draw a line from anterior superior iliac spine down to the table, and another line from the tip of the greater trochanter towards this first line, and the point of bisection of these two lines is the point of incision for this surgery. So I am making an incision at these bisecting points where the two lines bisect. So I am giving incision about 2 centimeters, as you can see in the picture. So I am feeling the correct point of entry. It should be at the junction of the anterior 2/3 and posterior 1/3 in lateral view, and in LD view it is just medial to the greater trochanter in the piliform fossa. So I am feeling with my fingers the correct entry point. So after feeling this, I am confirming I am introducing a bone out at the correct point selected, and then I am confirming this whether this bone out is entering at correct selected point or not in CR picture. So I am introducing the owl in correct position, and the guide wire is entering inside the intramedullary canal along the depression or groove present laterally in the owl. So it is inside the intramedullary canal, well placed in a view. And now I will remove the owl. I have removed the owl, and now I am introducing the nail of selected size, and I will hammer the rebar with the help of supine drive. I am hammering the nail inside the intramedullary canal so that the hole present, and so I am compressing the spiral blade by clockwise movement and removing the screwdriver by anti-clockwise movement. So the spiral blade is introduced in proper position, both anterior and lateral view, and then my assistant is attaching the arm for digital locking on the jig, and after measuring the screw size, I am introducing the drill sleeve for drilling the vortex for digital locking, and this is the 2.5 millimeter guide wire. I am introducing, just perforating making a dimple on the lateral vortex. I am hammering this hard and stout guide wire in the lateral vortex, and after confirming it in CR picture, I am drilling with the power drill both lateral and the first vortex is drilled, and now second vortex, and this is the IP view. You can see that it is in good position, and this is the lateral view of distal screw. It has been introduced in proper position in the hole, and this is the lateral view. The spiral blade has gone in the central position in lateral view also. So I will give a forceful. This surgery is well indicated for the osteoporotic patient with an unstable type of intertrochanteric fracture, because the very design of the spiral blade provides a stable fixation, and we can mobilize the patient from second post-operative day. So this is the lateral view, And this is the FD view post-operative. So thank you everybody. My anesthetists, my assistant, my supporting staff. I think this is the well-executed strategy for a old osteoporotic patient, for unstable type of interconnected fracture. We can make this patient mobile from second post-operative day, which is usually required, although this was not a very displaced fracture, but to make the patient mobile, we plan this surgery for this patient. Thank you everybody. Hello friends, I am Dr. RCT Ortho, orthopedic surgeon, Chhapra, Bihar. Today, I am going to present my innovative work named Dr. Thakur Innovative Technique of Suprapatellar Nailing of Tibia. Tibial fractures are most common among the long bone fractures in human body. These are usually caused by high energy trauma or diaphyseal fracture of tibia in adults. In treatment of metaphyseal tibial fractures, concerns regarding difficulties with reduction due to anterior deformity becomes a challenge. Suprapatellar nailing becoming popular choice for treating metaphyseal fractures. It is highly specialized surgery and requires very highly specialized instruments, sets and implants that tends to be very costly. Dr. Thakur innovative technique comorbidities. All surgery were performed after an average of 5.5 days, the range being 3 to 12 days after accident. To with the help of color-coded. The final observation, operative time was in this study 80 plus minus 10 minutes. Range was 65 to 110 minutes. Average fluoroscopy during surgery was 38.5 plus minus 6.5 seconds. The range being 10 to 50 seconds. The average time of union I done for in hours. These are the results. Duration of this surgery, the number of cases included in this study was small. The standard technique. Whereas the standard instrument sets are very, very costly. This technique can be adopted in smaller and medium class orthopedic hospital. If the only disadvantage of this technique is the slightly more radiation occurs because the locking both proximal and distal are done with freehand technique. But this can be lessened by gaining